Team dynamics are critical during a resuscitation attempt. The interaction among team members has a profound impact on the effectiveness of each individual as well as the patient's overall survival. The better you work as a team, the better the potential outcome for your patient. That's why it's so important that you understand not just what to do in a resuscitation attempt, but how to communicate and perform as an effective team, regardless of your role as team member or team leader. Welcome to the American Heart Association's megacode and team resuscitation video. In this video, we're going to demonstrate and model an effective resuscitation team in a case scenario. Our simulation will have 6 team members. You may have fewer members depending on the situation, so be prepared to adjust your roles accordingly. Our case study begins in a local emergency department, where a 65-year-old woman has been brought in complaining of epigastric and back discomfort.
Hello, I'm Dr. Jackson. What's bothering you today?
Oh, doctor, I don't feel good. I feel really bad. I'm dizzy and I'm sick at my stomach. My son was really worried about me and he brought me in.
Okay, are you having chest pain right now?
No, but I'm hurting. It started in my stomach and now it's in my back.
Okay, we're gonna see if we can find out what's going on, okay? Joette, do we have a set of vitals from Ms. Fernandez?
Yeah, blood pressure is 70/40, heart rate is 45 beats per minute, respiratory rate is 16 breaths per minute, and pulse ox is 92%.
Okay, let's go ahead and start her on 2 liters of O2. Ms. Fernandez, we've got you hooked up to a monitor so we can take a look at your heart rhythm, okay? And we've started you on oxygen so you can breathe a little easier.
Your pulse ox reading is 95% with 2 liters of O2.
Oh,
Okay.
oh, doctor. Oh, doctor, I feel really dizzy.
Okay, it looks like we have sinus bradycardia. Dana, let's go ahead and get an IV started right now.
Ms. Fernandez, Mrs. Fernandez, can you hear me? Mrs. Fernandez. She's unresponsive. I don't feel a pulse.
Okay, let's call a code. The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access.
24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Drawing 1 milligram epinephrine.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient remains in VFib. The protocol for this biphasic device is escalated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR.
Continue compressions. 1, 2, 3.
Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Drawing 300 milligrams of amiodarone.
Sam, are you getting good chest rise?
Yes, and I'm being careful not to deliver ventilations too quickly or forcefully.
Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient is in persistent VF. Let's shock again at 360 joules.
Charging at 360 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
Continue CPR.
Continuing CPR. 1, 2, 3, 4.
We can give amiodarone now?
Thanks, Shelley. Dana, please give 300 milligrams of amiodarone.
Okay. 300 milligrams of amiodarone given. And the IO is flushed.
We've given 3 shocks. After the second shock, we administered 1 milligram of epinephrine, and we've just given 300 milligrams of amiodarone. Our next drug will be vasopressin. Dana, please prepare 40 units of vasopressin.
Drawing 40 units of vasopressin.
12, 13, 14, 15, 16, 17, 18, 19.
Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting a chest rise.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze, switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
Continuing chest compressions. 1, 2, 3.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay, Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed.
Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze, switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
I can feel a rapid, weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing.
Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch out for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's the 12 lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest.